Hello class. I'm going to begin this lecture on the topic of hypertension. Definitely a very common cardiovascular problem that we see. Hypertension is a fancy name for high blood pressure. It's one of the most common health problems seen in the acute care setting. And our concern with hypertension is the fact that over time, if it's left untreated, we see the devastating effects such as stroke, myocardial infarction, kidney failure, and even death, because our goal is to hopefully get this under control and to prevent things like malignant hypertension or to prevent the patient from going into a hypertensive crisis. And most hypertension can be definitely controlled today, especially with medications, and really teaching the patient about making some very significant lifestyle modifications. And I think it's also important that they do understand their medications and how important it is to take it, even when their blood pressure is in a normal range, because with the constant administration of that medication, it continues to keep their blood pressure at a desired outcome. And I think that's what's really important to emphasize to these patients, along with, teaching them about diet, exercise, reducing stress, and maybe even possibly losing weight. Sometimes changes in lifestyle can really make a significant impact on patients that have some of these issues, especially something like hypertension. And unfortunately, with hypertension, some people don't even know that they have it, and that's the danger of hypertension. And of course, when we suspect someone may have hypertension, there's no one diagnostic test that proves that they do have hypertension. And many times, hypertension could be a sign of some other serious underlying pathology that is occurring with your patient. And we've, heard the term with hypertension that without people aware that they even have high blood pressure, being completely asymptomatic, we can refer that hypertension as the silent killer. And it's really important too, and I think this is just an important fact to kind of iterate within hypertension, is the fact that we need to make sure that the patient does have hypertension, that it is an accurate blood pressure, that people who are taking blood pressures are taking them correctly using the proper cuff. As you can see, blood pressure cuff is huge. If the cuff is too small, it will indicate that the blood pressure is too high. If the cuff is too big, blood pressure could be too low. So, and we're treating patients according to this reading. We need to make sure that that is exactly what that patient's blood pressure is. So please, as the registered nurse who's in charge of your ancillary people who are taking blood pressures, particularly your PCNAs, make sure that when you have either a very large or a very small patient, that the proper cuff size is being used so that we can get accurate readings. Because as I said before, so many of these patients have underlying problems, and if we're treating cardiac issues which can affect blood pressure, we want to make sure that that blood pressure is accurate, because we don't want to hold meds if the blood pressure isn't too low, or maybe the patient needs their meds tweaked and maybe we need to increase the dosage or the frequency because it's really not giving us a true picture of what the patient's actual blood pressure is. So that is extremely important. So as the nurse, take time to walk down the hallway and watch people take blood pressures and make sure that they're being done correctly, okay? Because I think now it's modern times where in the acute care setting we're using such things as Dynamaps, and that's all fine and dandy, but we need to make sure that those Dynamap readings are accurate and they are exactly what our patient's blood pressures are being indicated to us. And So I guess we use the term hypertension, but we really need to ask ourselves, how do we define hypertension? What numbers are we talking about that would indicate that a patient does have hypertension? And the Joint National Commission on the Prevention, Detection, Evaluation, and Treatment of High Blood Pressure really defines hypertension as a systolic pressure greater than 140 millimeters of mercury and a diastolic pressure greater than 90, based on the average of 2 or more accurate blood pressures taken during 2 or more contacts with a healthcare provider. And that's very important. I mean, just an isolated blood pressure that may be elevated could be due to various factors. Patient could be nervous. Patient could just have had 3 cups of coffee. Would not necessarily diagnose them as being hypertensive. So that's what it's recommended, that we do an average of 2 in a situation that is done in a correct and justifiable way, so that we can definitely diagnose that patient as having hypertension. This is a table which kind of looks at those numbers when we take blood pressure, because we can also stage them or classify them according to normal, pre-hypertensive, stage 1 or stage 2. And again, it's based on that average of 2 or more properly measured, and that's very important. Seated readings taken on each of 2 or more office visits, okay? So please keep that in mind. And it's also important too that communication is very good among all the people involved who are taking your patient's blood pressure. That you tell them, please come and tell me if somebody's blood pressure is this or that. Give that person parameters. They don't have the knowledge that you do as a registered nurse, so they're not going to know that maybe an 88 blood pressure systolic. Hopefully they do, but if they don't, that's your responsibility to make sure that they're aware that that's when they come in to communicate to you that the pressure may be too low or maybe a pressure may be too high. So please make sure that you let people know when you want to be aware of what that patient's actual blood pressure is. Because maybe we need to take it again. Maybe we need to take a cuff pressure and see if it matches or it's very much correlated with a dynamap pressure. There's a lot of factors that influence the development of hypertension. Obviously, one is increased sympathetic nervous system activity, and we've talked about that various times, where when sympathetic nervous system is stimulated, we're going to see more of an increased heart rate, which can definitely affect blood pressure. Increased reabsorption of sodium, chloride, and water by the kidneys. This could be an element of the renin-angiotensin-aldosterone system. Again, increased activity of the renin-angiotensin system. Decreased vasodilatation, where you have more vasoconstriction, which puts more peripheral vascular resistance, causing blood pressure to increase. And again, patients that are insulin resistant, patients that become type 2 diabetics, we see very much the correlation of high blood pressure with type 2 diabetes. And these are a lot of the factors. And this is a slide that really shows you all the various factors that actually affect blood pressure. And they put this more in a view for you. And you can see there's quite a lot, okay? See, we go back to preload, contractility. We've talked about excess sodium intake. That's why patients need to be instructed on how much sodium to have in their diet. Understanding and reading food labels. Fewer nephrons, that has to do with renal capacity or renal function, stress, genetic alteration, obesity, endothelial factors. So you can see that all these really play a part in what someone's blood pressure will be. And as I said before, many times patients can be very, very asymptomatic with hypertension. Sometimes they can absolutely manifest no symptoms whatsoever, other than the fact that you take that patient's blood pressure and it's elevated. And symptoms seen related to organ damage are seen late and are serious, and that could involve retinal or other eye changes, renal damage, myocardial infarction, cardiac hypertrophy, and of course stroke. And these are some of the more prevalent risk factors. Obviously smoking, because we know all the toxins in cigarettes, that affect the health of the vascular system, causing a lot of vasoconstriction, obesity, physical inactivity, dyslipidemia, diabetes, and again we talk about microalbuminuria. I've talked about that in relation to the glomerular filtration rate. That really does have to do with the glomerulus in the kidney, and we'll get into more of that when we get to the renal system. But when we see proteins in the urine, we already have some kind of renal impairment. As we age, you're more prone to acquiring hypertension. And of course, if you have a strong family history, that definitely will predispose you to hypertension. Before I begin to talk about hypertension, again, your book really does go over the pathology of hypertension when we talk about 4 systems that play a major role in trying to maintain your blood pressure. We've kind of touched upon these previously. I discussed it somewhat in the assessment of the cardiovascular system. Arterial baroreceptors. Those are found primarily in the cardiac sinuses, in the aorta, and in the walls of the left ventricle. And they actually monitor arterial pressure and counteract a rise in arterial pressure through vagally mediated cardiac slowing and vasodilatation to decrease sympathetic tone. So you can see again how the autonomic nervous system plays a role in trying to decrease that blood pressure. And another one is changes in fluid volume. And when you have a lot of excess sodium in water, blood pressure will rise through complex physiological mechanisms that actually change the venous return to the heart, producing a rise in cardiac output. But if the kidneys are normal, you can see a patient begin to diurese, and that will definitely bring down blood pressure, okay? And then, of course, we've talked numerous times about the RAW system, the renin-angiotensin aldosterone system, where you have angiotensinogen, which splits to angiotensin 1, converts by an enzyme in the lung, and that converts to angiotensin 2, which is a strong vasoconstrictor. And then we have the role of aldosterone, which actually works on the collecting tubules in the kidneys to reabsorb sodium. And we know when that happens, sodium increases blood volume, thus increasing blood pressure. And then there's also this process of vascular autoregulation, which keeps perfusion of tissues in the body relatively constant, okay? So I just wanted to kind of go over some of the mechanisms and the systems in our body that actually do help to control blood pressure, okay? So, just keep that in mind. And I'm definitely going to probably refer back to some of those when we talk about some of the reasons why patients do acquire hypertension. Now, there could be various reasons why somebody becomes hypertensive. And one of them, which is probably the most common one, is called primary or essential or idiopathic hypertension. And, somebody becomes hypertensive, and we really don't know what the cause of it is. And that really accounts for about 90 to 95% of all cases. And basically, it's not caused by any existing health problem that the patient may have. But there's a lot of risk factors that we look at that may be the reason why a patient really does become hypertensive. And I've already gone over those with you in previous slides. But unfortunately, when this occurs, just because there's no identifiable cause, it doesn't mean that the hypertension is any less severe. Over time, can cause damage to many of the organs, causing a lot of changes in the arterioles, making them more thick, and as those arterioles change in the way they accept perfusion in blood, this can really decrease perfusion and cause less nutrients and blood going to these various tissues and organs, okay? And this is why long-term hypertension causes all those serious complications like stroke, heart attack, and a lot of the peripheral vascular diseases that we see with our patients, and definitely kidney disease, okay? And so these are maybe the contributing factors, and we've talked about this so much, especially with increased sympathetic nervous system activity, increased sodium retaining hormones and vasoconstrictors. You can see the seriousness of when someone has diabetes mellitus, body weight that's probably higher than it should be, taking in a lot of sodium, and people that drink excessive amounts of alcohol. So secondary hypertension is just a little bit different, and we see this in about 5 to 10% of adults who have hypertension. And this hypertension happens because there is a underlying cause, and the hypertension is kind of secondary, and that's exactly what the classification of this hypertension means. You know, the primary problem is happening, and with that primary problem, we see a secondary problem of hypertension. And there can be many, many reasons why patients with secondary hypertension occur. Renal disease probably is one of the most common causes. Maybe in the renal artery, that patient may have stenosis. Maybe they have some problems in the adrenal medulla. Those are those adrenal glands that sit on top of our kidneys. Sometimes drugs, people that take outside sources of hormones such as estrogen, maybe women who go on oral contraceptives, sometimes glucocorticoids may affect blood pressure. But there's all kinds of reasons. But there is a way in which we can pinpoint that primary problem that is causing that patient to develop secondary hypertension. Okay, and another one I wanted to mention, and I didn't put it on the slide, is malignant hypertension. And this is really a very, very severe type of elevated blood pressure that rapidly progresses, okay? And please understand how this begins to occur. The person with this health problem will really start to have very pronounced manifestations that go along with the high blood pressure. They might wake up in the morning with headaches. They might have blurred vision. They might also have shortness of breath. So we see this in patients who are often maybe in their 30s or 40s where their blood pressure is extremely high. And we're talking about systolic blood pressure that is well over 200 millimeters of mercury systolic. And the diastolic may be well over 150 millimeters of mercury or greater. And obviously, this is something that we need to take care of as soon as possible, intervene quickly, because this is a blood pressure that is going to cause extensive damage to organs such as the heart, such as the kidney, and of course really puts our patients at risk for the chances of having a stroke. Okay, so you know, just think about that. Also, patients may also have uremia, okay, where they have some of those toxic waste building up in their body because the kidneys are not really working well. And with cardiac involvement, we might see patients really begin to develop left ventricular failure. So what is going to essentially happen is they will probably go into some severe form of heart failure. And I just want to kind of gear you towards your book. There's a nice chart, table 36.4, which really gives you a lot of the etiology of hypertension concerning either essential or primary hypertension as well as secondary. So please look at that and review that because it's really important to kind of differentiate what kind of hypertension your patient may have. As I said so many times before, the more we know about our patients, the better nurses we can be to that patient. And it really would be very helpful to be able to determine where their hypertension problem originates from. Because many times, especially with secondary hypertension, if we find out that primary cause, the patient may no longer have hypertension anymore. So that could be very helpful. And then we kind of alleviate two problems at one time, because if we just go ahead and treat the hypertension, we're not looking at what that primary cause would be. And if the patient does have, for instance, renal stenosis, maybe it could be something as treatable as putting a stent in the renal artery to open up that renal artery so it can better perfuse the kidney. So this is just kind of what I'm kind of explaining to you, that just knowing their patient has hypertension is not enough. Let's find out why they have hypertension. Is there a primary reason, or is it a secondary reason? Okay. And as we kind of find that our patients do have hypertension, again, that all important knowing about their history, doing a good assessment. And I'm not going to read these, but you can see all the personal, social, and financial factors that will influence the condition or its treatment. And really seeing maybe how long that patient has maybe had hypertension, doesn't even know they have hypertension, and if they've had it for a while, has it caused any target organ damage? And also looking at, does the patient have any of these other manifestations? Angina, shortness of breath, all these things that could indicate stroke, retinal problems. You know, have they had nosebleeds for a while and just attributed to the fact that they had dry sinuses or their mucous membranes were dry, but really all along their nosebleeds were caused by the fact that maybe their blood pressures were up. How are their apical and peripheral pulses? All part of that, all important assessments that we continuously make on our patients. So let's talk about how do we obtain an accurate blood pressure that really is exactly what's going on with our patients, okay? How do we actually measure blood pressure? First of all, I've mentioned earlier, use an appropriate size cuff to ensure accurate readings. And this one is very important too. You know, if you go to your physician for a physical, see if the nurses are implementing these. Is the patient seated quietly for 5 minutes in a chair with feet on the floor and arms supported at the heart level? And, you know, think back when you were in your earlier nursing courses, when you learned how to take blood pressure. Were you implementing these ways in which to provide an accurate reading on your patients? Obtain at least 2 measurements. Remember, blood pressure is typically highest in the morning and lowest at night. And here's a nice question to think about, whether the following statement is true or false. Normally, blood pressure should vary by no more than 10 millimeters of mercury between arms. Sometimes you might want to look at blood pressure in both arms, you know, left and right, to see if we see any significant variance in those numbers. So you might want to think about this question, and then we can discuss it in class when we meet again. Just want to tell you that the incidence of blood pressure is about 1 in 3 people have increased high blood pressure. And, you know, you might not think it's very significant, but with untreated blood pressure, it can actually shorten one's life. More men than women until the age of 45. And then after 54, women seem to have more problems with blood pressure than men, okay? And most people really do not have many symptoms, but some people will have a headache, sometimes dizziness, fainting, sometimes facial flushing, nosebleeds. So these are things that doing a very thorough history on these patients really helps you to kind of get a good idea that maybe they've been having associated symptoms that they did not correlate with high blood pressure, okay? And that's why it's so important that you really do a good history on these patients, because sometimes when we look at just their dietary habits, it makes sense that their blood pressures have been high, because you notice that, you know, they're eating a lot of canned foods or they're eating a lot of frozen foods, and we know that a lot of those foods contain high levels of sodium, okay? You know, and you also want to take in consideration, too, that, you know, when patients go to the doctor's office, they're nervous, so sometimes that could raise blood pressure up a little bit. So that's why it's kind of good to encourage them to sit there for a few minutes and kind of relax and calm themselves down so that their blood pressure isn't elevated due to kind of that white coat syndrome or that anxiety when they go to their physician about any kind of health problem. And as I said, these are many of the signs and symptoms that you will see when a patient does have hypertension. Okay. So let's talk about some of the diagnostic studies, okay? Oh, before I forget too, I just wanted to talk about, I forgot to mention the fact that when we're taking blood pressures in both arms, it's also important to kind of look at if the patient has any orthostatic changes that occur. And what you would do is, and many times this is ordered by the physician, you might want to take readings with the patient in the lying position or the sitting position, and then at least 2 minutes later when they actually get up in a standing position. And what defines if they have orthostatic hypotension is a decrease in blood pressure, 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic, when the patient changes their position from a lying to a sitting position. So that's important to pretty much kind of determine if that's going on, okay? So I just wanted to bring that up because that's very important. And a lot of times your physicians will order that. And as I said, many of the physicians can look into the fundoscopic examination of the eyes to see if there are any vascular changes in the retina. And usually that's done by somebody who does have good experience in determining that, because the appearance of the retina can really be a reliable source if the patient has severity and prognosis of hypertension. And I talked earlier about renal stenosis, and what's important too is sometimes that can be associated with the fact that the patient may have an abdominal bruit. And we know what bruits are. They're like that swishing of sound through a narrowing vessel. That's the blood flow going through that. So, and then there's also things that we'll talk about more when we talk about adrenal tumors in the adrenal glands that sit on top of the kidneys. And then, of course, coarctation of the aorta is evidenced by elevation of blood pressure in the arms with normal or low blood pressure in the lower extremities. And with that, we might also see changes in the femoral pulses. They can either be delayed or absent. So just wanted to kind of give you those assessment findings so that if you happen to read those in your patient's history or their physical exam by their healthcare provider, it will make more sense to you that that's why they're doing those kinds of assessments, and this is what those findings kind of tell the patient about. Tell the physician about their patient's health. All right. And sometimes blood pressure can be very much equated with a patient's stress in their life in regards to, their job. What kind of economic situation are they in? Are they financially strapped? People cope differently with certain stressors that are given to them, but maybe some people just really do not cope very well, and this really could be the reason why some people do have more higher blood pressures than others because of the stress that's in their life. All right, now we can get to the diagnostic studies, okay? And as I said before, there really are no laboratory tests to diagnose at least essential hypertension. But we can see some diagnostic studies that can possibly tell us what's causing their secondary hypertension, okay? And, of course, urinalysis is huge, along with creatinine clearance, because that really relates to the fact that a patient may have kidney disease with the presence of, protein, red blood cells, and maybe their BUN and their creatinine levels are elevated. We know the creatinine clearance really kind of gives us evidence of exactly what the glomerular filtration rate is of their kidneys, okay? And it really gives us a better and a truer indication of their kidney function, okay? And then, of course, serum electrolytes, glucose, even looking at catecholamines, because maybe some patients may have what we call pheochromocytomas, and those are actually tumors in the adrenal that kind of secrete large amounts of the catecholamines, for instance, epinephrine, norepinephrine. So those could be causing the patient's blood pressure to go up. Obviously, serum lipid profiles, which could show evidence of cardiovascular disease, ECGs, and echocardiograms, okay? Because we really want to look at that echo and determine how much cardiac involvement is occurring. Is there hypertrophy noted, atrial versus ventricular, because of the fact that the patient has had hypertension. And these are, again, all the medications that we use, and we'll talk about these in just a few minutes, because, as I said, the primary way in which we treat hypertension is through medications. And these are how some of these meds that maybe are familiar to you, where they work, and how they actually affect blood pressure and hopefully bring the patient's blood pressure down, okay? So let's go and talk about this. Now, this is huge, and you all have to really think about the medications, because some of these might be familiar to you, for the fact that you've seen some of these before, because we might use them for other reasons. Our patients might have other forms of cardiovascular disease. And, you know, for instance, some of the meds that we're talking about in regards to heart failure are very much used for hypertension. So they're still going to work the same way, but that is the indication of why these particular meds are definitely ordered, okay? So usually that initial medication is a diuretic, a beta blocker, or both. Usually they'll start them on one and see how the patient does. And again, this is where we start to teach them about changes in lifestyle and, you know, watching their diet, maybe starting to exercise, maybe starting to lose weight. Because sometimes when those are implemented, blood pressure really starts to come back to a normal range. Of course, like any medication, we start at a low dose, and we watch them for a few weeks. If we're not getting the outcome that we want, then we can always increase that dosage or even add a medication to it. Sometimes patients can be very stubborn, and multiple medications may be needed to actually control blood pressure. And again, lifestyle changes may also need to be implemented to help the patients get to that target range that we hope to achieve. All right, so let's talk about some of these meds now, okay? Your first group of medications are your diuretics, and we talked somewhat about these when we talked about heart failure, because obviously those are very important in bringing down blood pressure. Your thiazide diuretics, which are not as potent as your loop diuretics. Your thiazide diuretics, be sure your patients don't have any allergies to thiazide. Loop diuretics, such as furosemide or Lasix, Bumix, those high-ceiling diuretics. Because remember, think about how these work. We've talked about this already. They cause a diuresis and decrease vascular volume, thus decreasing preload, then hopefully decreasing afterload. And as I said before, the thiazide diuretics, I'm just trying to give you an example of those. Let me think about what medication would be a thiazide diuretic. I just wanted to let you know some of the more popular thiazide diuretics are, one is Zeroxolin. That definitely is one of the most popular ones. Let's see another one. Microzide is another one that we see very frequently. Diarrhea. Those are all types of thiazide diuretics, okay? And and what they do basically, they kind of increase urinary flow. They act directly on the kidneys, and they, again, like your loop diuretics, promote diuresis. They inhibit that the sodium and chloride cotransporter located in the distal convoluted tubule of the nephron. And they actually decrease sodium reabsorption, which will increase fluid loss in the urine, okay? So, and really what it does too, it also affects cardiac output, and so the heart doesn't have to work as hard, and it definitely lowers blood pressure, okay? They also can, again, just like your loop diuretics, cause potassium loss while retaining calcium. So that's your thiazide. Loops we're very familiar with. Furosemide, those are high-ceiling diuretics that inhibit sodium and chloride and water absorption in the kidney's loop of Henle, okay? And I guess with those, because they're those high-ceiling diuretics, you really need to watch for severe loss of potassium and really watch for dizziness or any signs of hyperkalemia, okay, or severe dehydration. Another type of medication, too, is your hydrochlorothiazide is another common one. It's one of those low-ceiling diuretics that maybe the patient may start off on if their blood pressures are just a little bit up. And so that's another common one that you may see. And again, those also cause potassium and magnesium excretion. And so you really do have to watch when these patients are on diuretics that they're not losing too much fluid, where we could bring their blood pressure down too much and cause dehydration or orthostatic hypotension, okay? So, you know, initially you might want to teach especially the elderly to rise very slowly from a chair or a bed and use with caution with patients with diabetes, because these can actually affect their blood glucose levels, and also patients that have problems with gout, because some of these drugs can cause uric acid retention. So that's why it's so important to know what your patient's history is and some of the issues and problems that they may have, okay? Another one is your potassium-sparing diuretics, and an example of that would be your aldactone or your spironolactone. That really causes potassium retention in the body, and so so maybe with these patients, especially if they have low renal insufficiency, you may teach patients to decrease their intake of foods high in potassium and make sure that they're going to their physicians or going to the lab often to check their potassium levels, so we don't have any problems with hyperkalemia, okay? And then another one now is your aldosterone receptor blockers. And an example of your aldosterone receptor blockers is Inspra, okay? And it does exactly what, you know, the name says. Remember, aldosterone is part of the renin-angiotensin system, so if it blocks the secretion of aldosterone, we're not going to get that next step of sodium and water retention, thus decreasing vascular volume, thus decreasing blood pressure, okay? And then your beta blockers, which we've talked about with your patients that have heart failure. It's going to definitely affect blood pressure and heart rate as well. So we want to monitor carefully for orthostatic hypotension. Again, watching the patients to teaching the patients about taking their own pulse, so we don't bring the pulse rate down too much. And with your beta blockers, it really decreases the rate and contractility and output of the heart. So we just want to make sure the patients are doing well and tolerating the medication well. So that's why we'll start them on lower doses of this medication. Okay? And then your central alpha agonist and other centrally acting drugs, such as cataprase, kind of a popular medication, prevents the reuptake of norepinephrine and results in a decrease in peripheral vascular resistance and blood pressure. Okay. And then your next ones are your alpha adrenergic antagonist. Let me bring this down in the screen. Your mini-press, your Cordura, your Hytrin. These have dilating effects, decrease hypertrophy, and hopefully increase blood flow to the heart muscle. They actually work by dilating the arterioles and veins. So that's how these medications work. And of course, we've already talked about some of the vasodilating medications. Things like nitrates, even your angiotensin converting enzyme inhibitors. We've talked how those work in regards to the renin-angiotensin-aldosterone system. And then, of course, your angiotensin II antagonist is another category of medications that your patients may be on. And these are basically your ARBs, such as Cozar. And just remember to watch your ACEs, patients developing side effects such as cough, might increase potassium levels, so just keep an eye on that. Another category is your calcium channel blockers, and we know that interferes with the influx of calcium ions that help to cause vasodilatation, which again lowers blood pressure. Examples of that are, verapamil or Calan, and that's the purpose of why those would be given for blood pressure. It's that vasodilatory effect, and really decreases, peripheral vascular resistance. And then your Tecturna, which is basically a renin inhibitor, and it inhibits renin production, which prevents the conversion of angiotensinogen to angiotensin I, and helps to decrease that vasoconstriction, peripheral resistance, and cardiac output results. Usually patients do pretty good on that. Again, vasodilates, decreases blood pressure, peripheral resistance, and hopes to definitely increase cardiac output. These probably are some of the less common categories that we see prescribed, but they can be, okay? Most people need 2 or more drugs to control it. Sometimes, a patient can get by with 1, especially if it's mild hypertension, and as I said before, making some lifestyle changes. You have to also consider, too, that when your patients may be like in their 40s or 50s, you also want to watch these medications, because some of them can affect libido and sexual functioning, especially some of your beta blockers, your thiazide diuretics. Those are very cost effective, but they can really have some significant problems with your patients who, are young and, really can interfere with their sexual functioning. And you want to be very sensitive to that, and hopefully that they can be honest with you and come to the healthcare provider's office and really discuss that this is a side effect that's really causing them a lot of problems in their, personal life. Okay. And I've already talked about some of these already. Your alpha adrenergic, your mini-press, dilates arterioles and veins, decreases blood pressure. We see those often used for men that have BPH, benign prostate hypertrophy. So you'll see that with sometimes your male patients who have hypertension. And of course, this is The lifestyle modifications, when we talk about weight reduction, and the DASH eating plan. And as you can see, the DASH is all in capital letters, and that is an acronym for Dietary Approaches to Stop Hypertension. And as you can see, the eating plan really consists of a lot of fruits, vegetables, and low-fat milk products with reduced saturated fat. It's a very good way and a very healthy way to eat. But as you can see, it has lifestyle modifications has to do with weight reduction, DASH diet, sodium restriction, physical activity, and moderate amount of alcohol. And as you can see, it can have a significant reduction in systolic blood pressure, as you can see here. Sometimes just losing 10 kilograms, which is a little over 20 pounds, can actually bring someone's blood pressure down from anywhere to 5 to 20 millimeters of mercury. So that may be in itself enough to get the blood pressure more in a normal range. And again, the goals are to understand the disease process, understand their medications and the treatment, and really to be really much in charge of their blood pressure, and really to prevent an absence of complications. Okay. And again, patient teaching, patient support, and really further consultations with physicians, collaborate, follow-up care. Checking blood pressure periodically if you don't have your own blood pressure cuff at home, maybe having lab tests done to assess, lipids, electrolytes, things like that, and really know that this is something that you don't do for 1 week or 2 weeks, that it really is a lifelong process to stay healthy. And ultimately it's those severe complications that cause patients to get really sick and develop some really serious problems because their hypertension is not very well controlled. Again, strategies for adherence to regimen. Really, empathize, increase patient trust, motivation, and adherence to therapy. And really think about, their dietary needs, especially if they're from certain ethnic background. We don't expect people to give up everything that they've grown up with or been accustomed to, or which they practice within their tradition of their family or family history. So we need to be very sensitive to that. The one thing I do want to go over real quick is a hypertensive emergency. Okay, I'm trying to bring this down into the screen. It kind of changes with every screen. This is a very serious situation where you've got someone who's become very symptomatic and has a very elevated blood pressure, anywhere beyond 180 systolic with a very high diastolic. And we need to get this down very fast, because our concern now is that these patients may have a serious stroke and cause the need to prevent any damage to, prevent any damage to target organs, okay? When they come in, they're going to feel really bad. That's why they're probably coming in and seeking medical attention. So our goal is to get that blood pressure reduced to about 25% in the first hour, and then gradually bring it down over a normal period of time. The only situations that we wouldn't want to bring blood pressure down too low are ischemic stroke, because obviously ischemia means the fact that there's no blood supply going to that, and aortic dissection, because we need a certain pressure to prevent that dissection from totally occurring. So those are the two only exceptions. Not that we want a really high blood pressure, but we don't want to bring it down too low. And these patients may have very significant headache, dizziness, blurred vision, or may be very, very much disoriented. Get them on some oxygen, semi-Fowler's positions, and some of the IV vasodilators are your sodium nitroprusside. We used to use this a lot in intensive care. And what you do is you cover the bad, because it prevents the breakdown of the drug by light. Our concern is, too, as we're trying to get this blood pressure down, you also want to be assessing their neural status, watching them for a chance of developing seizures, listen to them if they're still conscious. Are they having any numbness, any weakness? Are they moving all extremities? How are their pupils reacting? Do they know where they're at? Some of them may be a little bit out of it, but you really want to keep tabs on neurologically what this patient is doing. We just want to prevent any type of neural complications. A lot of these meds, they're very, very hard to pronounce, but many of them just really produce a vasodilatory effect for short-term purposes. So that's why, that's basically what we're doing. Some of them at the time when their blood pressures may be elevated may have, a serious nosebleed going on, and a lot of them will feel extremely, extremely anxious. So that's one thing that you want to stay with this patient, try to alleviate some of their anxiety, put the patient in a semi-fullness position, give them some oxygen, and maybe get an IV going, and maybe they start some normal saline to prevent fluid overload, and they'll start to give this one med, nicardipine, which will help vasodilate and bring down blood pressure. Okay. But you really want to watch, you'll have them on a heart monitor because, again, we want to assess for any kind of dysrhythmias. Many times with blood pressure this high, some patients may experience chest pain. So, we're going to be having this patient on frequent blood pressures or continuous blood pressures along with pulse ox, making sure that they're oxygenating properly. And again, as I said before, the all-important watching their neural status, okay? And then later on, we want to find ways in which we prevent this hypertensive emergency from happening, because this is extremely hard on the patient's body and their hemodynamics. And again, we want to prevent any kind of tissue damage or target organ damage with this reoccurring hypertensive emergency. And we never know always what initiates this. Maybe the patient was feeling well and had not really been very compliant with their medication. And that's one thing that we excuse me, we often see with patients who, after they've been on their meds for a while, they feel very well, and they think, oh, I don't need those blood pressure medications anymore because my blood pressure is like 120 over 68, and I'm feeling so good now. So they quit taking it, and that's the most serious thing that they could possibly do, because that could put them in a situation where all of a sudden, with changes in lifestyle, factors, or not taking their medications, or some kind of stressor in their life, their blood pressure shoots up, and this could be putting them in danger of a hypertensive emergency. So that is really part of the teaching that we want to do on these patients to make sure that they very, very much are compliant with their medications. And that's your hypertension lecture. Please let me know if you have any questions. I think that is sufficient enough of information so that you have a good idea of how serious this can be and what can happen over time when it's not well controlled, and really getting a good understanding of the medications, which very much overlap with some of the medications that your patients have been on for cardiac problems. Because like I said before, your beta blockers are often the drug of choice for patients with high blood pressure that also have ischemic heart disease, because your heart really is one of those most frequently sought out organs that will be very much affected by patients who are not well controlled with their hypertension. So have a nice day.